Hello and welcome to Medaculus. Today's topic is ankylosing spondylitis. Spondyloarthritis is a term describing a group of clinically heterogeneous inflammatory rheumatologic conditions. It may be axial, affecting the sacroiliac joints and the spine, or peripheral, psoriatic arthritis, reactive arthritis, or enteropathic spondyloarthritis. Ankylosing spondylitis, radiographic axial spondyloarthritis, is axial spondyloarthritis characterized by sacroiliitis on X-ray. Axial spondyloarthritis can also occur in the absence of X-ray changes, and this is classified as non-radiographic axial spondyloarthritis, although changes may be visible on magnetic resonance imaging. Both conditions have similar presentations. Some experts consider radiographic and non-radiographic axial spondyloarthritis to be part of a continuous disease spectrum rather than separate entities. However, not all non-radiographic axial spondyloarthritis will progress to radiographic sacroiliitis, and this finding alone is unlikely to be relevant to the outcome of the disease. Features of ankylosing spondylitis include chronic back pain, often inflammatory in nature, and stiffness that improves with exercise, not rest. Sacroiliac joint and spinal fusion. New bone formation leads to sacroiliac joint ankylosis and the formation of syndesmophytes, bony growths in intervertebral joint ligaments, in the spine. Arthritis and enthesitis. The most common peripheral manifestations, predominantly in the lower limbs with asymmetrical distribution. Dactylitis, swelling of a finger or toe. Fatigue. Extraarticular manifestations, for example anterior uveitis, psoriasis, inflammatory bowel disease. Prognosis. The course of ankylosing spondylitis is variable, but damage is progressive and irreversible. Axial spondyloarthritis is often characterized by persistent or fluctuating axial inflammation on MRI and structural progression on X-ray. Both the inflammation and new bone formation, if inflammation is ongoing, affect quality of life due to pain, reduction in mobility and function. Prognosis of ankylosing spondylitis also depends on the presence of extraspinal manifestations, for example uveitis, psoriasis, inflammatory bowel disease, the person's age at diagnosis, and the choice of treatment. Later in life, the risk of spinal fracture increases. The spine is made more brittle by rigidity and weaker by osteoporosis. Resultant fractures can therefore occur with minimal force. Causes. The pathophysiology of axial spondyloarthritis is not completely understood. It is thought that ankylosing spondylitis is triggered by an environmental factor or factors in people who are genetically predisposed. More than 90% heritability has been estimated for axial spondyloarthritis. The most important genetic risk factor is human leukocyte antigen B27, HLA, B27. The prevalence of HLA, B27 usually reflects the prevalence of axial spondyloarthritis within a population, but varies considerably between different populations. Microbiome alterations and abnormal bone formation are also thought to be involved with disease and its progression. Exposure of the immune system to microorganisms, for example from barrier damage to the skin in psoriasis or bowel in inflammatory bowel disease, may be of relevance for the pathogenesis of axial spondyloarthritis. Complications of axial spondyloarthritis include ankylosis or spinal fusion resulting from new bone formation, spinal fractures. People with spinal rigidity from the formation of syndesmophytes and osteoporosis have a fracture rate of up to 10%, which in some cases is associated with spinal cord injury. Hip involvement, affecting about a third of people with ankylosing spondylitis, which may require joint replacement. Anterior uveitis, iritis, lifetime prevalence of 30 to 40% in people with ankylosing spondylitis, particularly in males and people who are positive for HLA, B27. Osteoporosis. occurs in up to a third of people with ankylosing spondylitis. Cardiac complications. The risk of cardiovascular disease is thought to be increased in people with spondyloarthritis due to the systemic inflammatory nature of the condition. Long-term use of NSAIDs may also contribute to this risk, although it is unclear in this specific population. It is therefore particularly important to identify and manage modifiable cardiovascular risk factors. Cardiac complications of ankylosing spondylitis also include aortic and non-aortic valvular heart disease and congestive heart failure. Arrhythmias may also be present, for example ventricular and supraventricular extrasystoles. Lung involvement such as restrictive pulmonary disease and apical fibrosis. Dyspnea may occur as a result of costovertebral involvement decreasing vital capacity. Neurological involvement from vertebral fracture, dislocation, or cauda equina syndrome, sensory disturbance in lower limbs and perineum. Adverse effects from drugs used to treat the condition, for example NSAIDs, gastritis, ulcers, renal effects, biological DMARDs, infection, immunosuppression, malignancy. Decreased quality of life and work productivity due to pain, stiffness, fatigue, reduction in spinal mobility and physical function, and sleep problems. Diagnosis. Recognize that spondyloarthritis can have diverse symptoms and be difficult to identify, which can lead to delayed or missed diagnoses. Signs and symptoms may be musculoskeletal, for example inflammatory back pain, enthesitis, or extraarticular, for example uveitis and psoriasis. Suspect ankylosing spondylitis in anyone with chronic or recurrent low back pain, fatigue, and stiffness, especially if the person is 45 years of age or younger. The back pain has been present for more than 3 months. Back pain and stiffness is inflammatory rather than mechanical, and worse in the morning, lasting for more than 30 minutes, improving with movement. They have current or previous buttock pain, sometimes on one side and sometimes on the other, pain in the thoracic or cervical spine, arthritis, predominantly asymmetric and peripheral, enthesitis, anterior uveitis. This presents as an acutely painful red eye with photophobia or blurred vision, psoriasis or inflammatory bowel disease, or genitourinary infection. Symptoms wake them in the night, particularly during the second half. Symptoms respond to a course of nonsteroidal anti-inflammatory drugs, NSAIDs, within 48 hours. There is a family history of ankylosing spondylitis or spondyloarthritis. Other conditions with similar presentations have been excluded. Do not rule out the possibility of spondyloarthritis on the basis of a single sign, symptom, or test result. Refer to a rheumatologist for confirmation of the diagnosis, as this can be difficult. There are a number of different classification criteria available to aid the diagnosis of ankylosing spondylitis. Certain investigations can be arranged from primary care prior to referral. Investigations. Spondyloarthritis cannot be reliably diagnosed or ruled out by a single test. Consider testing for erythrocyte sedimentation rate, ESR, and/or C-reactive protein, CRP. Be aware that a diagnosis of spondyloarthritis should not be ruled out if CRP and ESR are normal. Follow local referral protocols on imaging the sacroiliac joints and spine, or seek specialist advice on imaging before referral. X-rays. Ankylosing spondylitis is suggested by X-ray changes of the sacroiliac joints and spine, including sacroiliitis, sclerosis, thickening of bone, erosions, and partial or total ankylosis, fusion of joints. Magnetic resonance imaging, MRI. In some people with symptoms of ankylosing spondylitis, inflammation of the sacroiliac joints can be detected on MRI despite an absence of changes on X-ray. The use of MRI has enabled an increase in detection of sacroiliitis and inflammatory back pain and the diagnosis of non-radiographic axial spondyloarthritis. HLA, B27, if available, perform an HLA, B27 test in primary care only if a person has exactly 3 referral criteria to help determine whether referral to a rheumatologist is necessary. Differential diagnoses of axial spondyloarthritis include degenerative or mechanical problems, most common. For example, degenerative disc disease, spondylosis, congenital vertebral anomalies, degenerative changes in the intervertebral, facet, joints, osteoarthritis of sacroiliac joints, fractures, infectious sacroiliitis, bone metastasis, primary bone tumors, spinal stenosis, hypermobility. Management. Person with suspected ankylosing spondylitis. Advise that diagnosis of ankylosing spondylitis can be difficult and referral to a rheumatologist is required for confirmation. Clinical features and diagnostic tests for ankylosing spondylitis can help make the diagnosis, but no symptom, sign, or test result in isolation is useful for diagnosis. The rheumatologist may arrange blood tests and X-rays and MRI if there are no X-ray changes. Treatment for suspected ankylosing spondylitis. Consider prescribing a nonsteroidal anti-inflammatory drug, NSAID, while waiting for referral. Take account of the person's risk of serious adverse effects, the safety profiles of individual standard NSAIDs or COXIBs, the person's ability to tolerate individual NSAIDs, their other medications, and their preferences. To minimize the risks of long-term NSAIDs, use the lowest effective dose. Monitor risk factors and consider the use of gastroprotective treatment. If an NSAID taken at the maximum tolerated dose for 2 to 4 weeks does not provide adequate pain relief, consider switching to another NSAID. If NSAIDs are contraindicated, consider prescribing a standard analgesic, for example paracetamol with or without codeine. Note that non-NSAID analgesics will not control inflammation. Refer a person with suspected ankylosing spondylitis. Refer to rheumatology for a spondyloarthritis assessment if a person has low back pain starting before the age of 45 years and lasting longer than 3 months, plus 4 or more of the following criteria. Low back pain starting before the age of 35 years. Symptoms which wake them during the second half of the night. Buttock pain. Improvement when moving. Improvement within 48 hours of taking a nonsteroidal anti-inflammatory drug, NSAID. Spondyloarthritis in a first-degree relative. Current or past arthritis. Current or past enthesitis. Current or past psoriasis. If exactly 3 of the additional criteria are present, perform an HLA-B27 test. If the test is positive, refer the person to a rheumatologist for a spondyloarthritis assessment. If axial spondyloarthritis is suspected, but the person does not meet the criteria for referral, advise them to return for further assessment if they develop new signs, symptoms, or risk factors, particularly if there is a history of current or past inflammatory bowel disease, psoriasis, or uveitis. Refer urgently, same day, to ophthalmology if anterior uveitis, iritis, is suspected. Suspect acute anterior uveitis when an eye becomes red and acutely painful, especially if there is also photophobia or blurred vision. Advice for confirmed ankylosing spondylitis cases. Provide the person with information including an explanation of axial spondyloarthritis and ankylosing spondylitis, prognosis of ankylosing spondylitis, likely symptoms and their management, extraarticular symptoms, for example uveitis, flare episodes. Consider a flare management plan tailored to the person's needs, preferences, and circumstances, including access to care, for example specialist rheumatology nurse, self-care, for example exercise, stretching, pain and fatigue management, potential medication changes, and managing the impact on work and daily life. Treatment options, pharmacological and non-pharmacological, and their potential adverse effects, for example, advise people treated with TNF-alpha inhibitors that they may be at greater risk of skin cancer. Self-help options, local support groups and charities, for example, the National Ankylosing Spondylitis Society, NASS, offers information and guidance on managing axial spondyloarthritis and ankylosing spondylitis and the services available locally. www.nast.co.uk. Advise the person that they may be more prone to fractures and that they should seek medical advice following a fall or physical trauma, especially if they have increased pain. Management of uncontrolled symptoms. Check compliance with and tolerance to exercise/stretching and current drug treatments. If the current nonsteroidal anti-inflammatory drug, NSAID, is ineffective, options to consider include seeking specialist advice, changing to another NSAID, adding additional analgesia, for example, paracetamol and/or codeine. Consider using an analgesic such as paracetamol or codeine. Note that non-NSAID analgesics will not control inflammation. Manage flares in primary care or refer to specialist care, depending on the person's needs. Referral should be particularly considered for people who have recurrent or persistent flares, are taking biological DMARDs, have comorbidities that may affect treatment or management of flares. If symptoms are poorly controlled despite appropriate treatment, refer for specialist rheumatology assessment or seek advice from the person's specialist. Follow up a person with ankylosing spondylitis. Follow-up is usually a shared care arrangement with the rheumatology service. Local practices vary. The frequency of monitoring should be decided by the rheumatologist in charge of management. Follow-up should monitor disease activity, progression, and response to treatment. This may include assessment of spinal movements, symptom control, for example pain, fatigue, morning stiffness, and the presence of symptoms indicating hip arthritis, inflammatory arthritis in other joints, or enthesitis. Extra-articular manifestations and complications, particularly uveitis. The impact of the condition on function and activities of daily living, including work. Adverse effects of drugs, nonsteroidal anti-inflammatory drugs, NSAIDs, and biological DMARDs. Monitor people on long-term, regular NSAID treatment for changes in their gastrointestinal, cardiovascular, and renal status. Ensure modifiable cardiovascular risk factors are managed if present, for example smoking, overweight, raised cholesterol, sedentary lifestyle, comorbidities. Ensure that a person with axial spondyloarthritis receives an assessment for osteoporosis every 2 years. Be aware that bone mineral density measures may be elevated on spinal dual-energy X-ray absorptiometry, DEXA, due to the presence of syndesmophytes and ligamentous calcification, whereas hip measurements may be more reliable. When to refer a person with ankylosing spondylitis. Refer urgently, same day, to ophthalmology if anterior uveitis is suspected. Suspect uveitis if the person has eye pain, eye redness, sensitivity to light, or blurred vision. Refer, with urgency appropriate to the clinical situation, to a specialist, for example orthopedics, if vertebral fracture is suspected, sudden occurrence of new neck or back pain even in the absence of trauma. There is refractory hip pain or disability in association with structural damage on X-ray. Hip arthroplasty may be considered. The person has severe or progressive deformity of the spine, despite non-surgical treatment that is significantly affecting their quality of life. Spinal corrective osteotomy may be considered. Urgently refer to or seek advice from rheumatology people treated with a tumor necrosis factor, TNF, alpha inhibitor if a serious adverse effect is suspected, for example, infection, immunosuppression, or malignancy. Seek advice from the person's rheumatologist if symptoms are uncontrolled despite appropriate treatment. If not already arranged by secondary care, refer all people to physiotherapy for an individualized, structured exercise program, including stretching, strengthening, and postural exercises and range of motion exercises for the lumbar, thoracic, and cervical spine. Consider referral for hydrotherapy to manage pain or improve function. Consider referral to a specialist therapist, for example physiotherapist, occupational therapist, for an assessment and advice on physical aids if the person has difficulty with everyday activities.